Professor Bhugra grew up in a small industrial town in North India and attended medical school at Pune University. He's the current president of the British Medical Association and Emeritus Professor of Mental Health and Cultural Diversity at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. His research interests are in cultural psychiatry, sexual dysfunction and service development. He has authored or co-authored over 400 papers and 32 books, which makes me feel very at times. So Professor Bhugra is going to speak this morning on mental health crisis. Now we only have Professor Bhugra till 12:30 and then has to dash for a train to head home. So we are going to keep tight for time in terms of the presentation, but there will be an opportunity for questions. So over to Professor Bhugra.
Thank you. Can everybody hear me at the back?
Yes.
Yeah, without the microphone? Perfect. Thank you very much for inviting me, and it's a real pleasure to be here. It's my first visit to Malvern, and I do regret my abject and groveling apologies for leaving promptly at 12:30, largely because I've got guests coming, and you know what that's like. So what I'm going to do, I'm going to speak for about 35 minutes. I'll give you some headlines about mental health and specifically challenges. But also then I have 20-25 minutes for questions and answers. And if anybody wants copies of the slides, I'm very happy to email them to you. Or if you want to sort of copy them now, that's fine. We're going to start with that, depending upon which studies you look at, between 1 in 4 and 1 in 6 people in their lifetime will develop one or more kinds of mental illness. That means basically that every family in the land is going to be affected directly or indirectly. And there are issues related to agricultural psychiatrists. Most of my research has been in cultural psychiatry, looking at impact of culture and culture on presentation and help seeking and models of illness. Rates do vary across cultures, and if we have time we can talk about that. But one of the challenges in the last decade or so is that are the rates of mental illnesses genuinely increasing, or are we really becoming much more sensitive? Or is there something else that's going on? And one of the big challenges for us as clinicians is, are we medicalizing normal human emotions? That you can't feel sad anymore, you have to be depressed. You can't feel happy anymore because you've got bipolar illness. So I think it's, with those caveats, we need to be looking at what we need to be doing, both in terms of providing services and in terms of seeking out services. And a big challenge certainly has been this new sort of term called social scaffolding, which means that previously we would go to the church or the temple or the mosque or the gurudwara, and you kind of met other people, you chatted a bit, you listened to the sermon, made you feel okay, it was kind of group cognitive behavior therapy. That's all fallen by the wayside. And in addition, there are specific issues related to vulnerable groups like the elderly, children, those with intellectual disability, lesbian, gay, bisexual, transgender, QI plus individuals, and their specific issues. And again, I think one of the big challenges for LGBT plus individuals has been that there is considerable research evidence that people belonging to these communities have higher than expected rates of psychiatric disorders. But when the laws change and equality comes in, rates start to disappear. And there is really wonderful data from various states in the United States where the state has changed its laws and brought in equality of gay marriage or same-sex marriage, things have changed. So that's a lesson in terms of what we can do and achieve. And we know that migrants get a very bad press. Migrants do have higher than expected rates of certain psychiatric disorders, but certain migrant groups do. Migrants are also much more resilient, and therefore they are much more into productivity and managing. So this is the other figure that you need to bear in mind, that half of all mental illnesses in adulthood start below the age of 15, and 3/4 start below the age of 24, which is unlike the physical illness, which generally starts at the other end of the age spectrum. So from 50, 55 onwards, I start developing hypertension, diabetes, high cholesterol, etc. And there are challenges for us when we are looking at why are we so swamped with psychiatric disorders. I mean, one is the Cartesian mind-body dualism. And if you look back what Descartes did, he created this dichotomy. Basically, that mind is, or the soul is the church's responsibility, and body is that of the doctors. And subsequently that became much more rigid in the sense that there was a perception that mind doesn't talk to body and body doesn't talk to mind. They're two kind of separate entities. And what that also meant that the stigma towards mental illness started to increase. Out of sight, out of mind, separate psychiatric hospitals, and life is never like that. So if you're feeling, if your diabetes is not under control, and you feel depressed, that is much more difficult to treat both. So you need to be treating depression as well as diabetes. And certainly in terms of the causation, we use biopsychosocial, anthropological, spiritual model. And quite often we tend to ignore, we just focus on biology because we feel confident in prescribing drugs. And certainly, many psychiatric disorders have a biological underpinning and they need medication, but not all. So we need to be thinking very carefully, and particularly, and again, when we look at the impact of geopolitical determinants on social determinants which affect mental illness. And quite often we just tend to ignore what's going on because we're so narrowly focused on what's happening. And the other challenge really is that mental health and mental illness are not two ends of the same spectrum. Going back to bipolar illness, if you have bipolar illness, what David mentioned last night is sort of used to be called manic depressive illness. So you either have mania or depression or some kind of mixed state. But in between episodes, if you are healthy, are you ill or are you healthy? So again, one of the challenges for us is to try and understand that mental health is a state of successful performance of mental function, productive activities, fulfilling relationships. And quite often, when you ask the patients as to what you want, we as doctors are interested in symptom reduction. Patients are much more interested in social functioning. That they want a job, they want some kind of relationship, they want a place to live, reasonable amount of money, which is perfectly human thing to want. But somehow we as clinicians are trained that you need to reduce symptoms. Patients can live with their symptoms as long as they can function. And again, that's a challenge for the society because increasingly in the last 20, 25 years in practice of psychiatry in the UK, it's become much more about risk assessment and risk management. said, lock him up and throw away the key. And I'll come back to that because that's a big challenge. We know mental illness is about alteration of thinking, mood, or behavior, and it's a society which decides what behavior is acceptable, normal, and what we need to do about that. And of course, there are a range of psychiatric disorders starting in childhood to later life dementias, bit about complexity and chronicity. And again, the third message is that the burden on society, economy, cultures, as a result of mental illness, is going to overtake that of cardiovascular diseases and cancers by next year. And again, there are questions that we need to ask why that should be. Is it because we are becoming much better at diagnosing? Is it because there's a genuine increase because people are aware? And WHO came up with this whole idea of mental health gap, which means that you need to treat 100 patients with condition A. But out of the 100, either people don't come to you or they don't want to carry on with treatment, so there's a gap. Now the fascinating thing is that the WHO focus has been on low and middle income countries which have argued that there's a massive gap because of lack of resources. But what WHO forgets is that lots of countries have very different models of mental illness. So people go elsewhere. They will not go and see a psychiatrist because it's much more stigmatizing. We did some work in Southall in London about 20 years ago, asking Punjabi women about their experience of depression. Punjabi as a language has no word for depression, but they all were able to tell us that they felt low, they felt sad, they felt life wasn't worth living, they couldn't concentrate, all the symptoms that we would recognize. What would you do? What's there to do? This is part of life's ups and downs. What's their explanation? And they would rather go to the temple or the mosque or the Gurudwara. And if you go to the temple 5 times a day, nobody will say, why are you coming 5 times a day? And again, part of the challenge for the society is to change that perception and prejudice to try and understand. Let me give you a clinical example from Western India, in the state of Gujarat. There is a holy place, grave of a Muslim saint, where people with mental illness go to pray. So the government decided that they would invest in training the religious leaders and put an outpatient clinic on the premises with a psychiatrist, a pharmacist, and a nurse. And now, when you go in, nobody knows whether you're going to see the psychiatrist or you're going to pray. So the psychiatrist prescribes you the medication, and pharmacist doesn't give it to you. Pharmacist gives it to the religious leader, who then gives it to the patient saying, this has been blessed. So compliance is 100%. So moral of the story is that we need to get outside of our comfort zone and think outside the box. And particularly as more and more people are retiring early, we need to be looking at how we can reduce that gap. And for addictions and other psychiatric conditions, even in the UK, there's a gap of 70%. So it's about stigma, discrimination, varying models, etc. So I wanted to take you through a journey on social discrimination against people with mental illness and the idea of social justice. We know, Virtue centuries ago highlighted the social origins of illness, and that medicine is a social science and politics is nothing else but medicine on a large scale. Makes sense. try telling that to politicians though. So the challenges to equity between mental health, resources needed to treat mental illnesses and resources needed to treat physical illnesses depend upon a number of factors. Stigma. Now stigma has a role to play. Stigma is about creation of the other. I am mentally well because you are mentally ill. I am male because somebody else is female. So it's a kind of binary creation of the other, as Verona Box calls it. But equally importantly, stigma serves a purpose because it confirms who I am. The way you see me seeing you. Yeah? So what we need to be thinking about is discrimination, which is about, and it will become clearer a bit later, it's about behavior. I discriminate against, I'm prejudiced against. And then there are other issues. So social justice is the virtue which guides us in creating these organizations called institutions. So those institutions are responsible for ensuring that we have social justice, which means that we all have a personal responsibility. Social justice goes with economic justice. And there are different principles of economic justice that I'm not going to cover. But social determinants of health affect everybody. We know, we've already heard from Alison about poverty. And we know that the rates of psychiatric disorders are related to unemployment, poverty, homelessness, overcrowding, and a whole range of other factors. And we need to be thinking about that, how do we reduce those health inequalities, and which means something else, which is about we cannot see health in isolation. Health has to be seen in conjunction with education, justice, employment, and other bits. So having a Department of Health and Social Care is fine, but how does it communicate with the Department of Education? How do they communicate with the Department of Employment, etc.? So we need to think, looking at this whole idea of health inequalities in a different way. So one of the other things that we need to be aware of is this notion of capability to be healthy, and whose responsibility is that this is, we know the causes, constraints, levels, etc. But the state tells us that smoking is bad for you. We know that. It took the state 50 plus years to ban smoking in public places. And in spite of that information, if people insist on smoking, where does that responsibility to be healthy lie? And this capability depends upon biology. Some things we can control, others we can't. Behavior, more often than not, we can and should. And external physical environment, we may or may not be able to control. And lastly, some of social conditions within which we live, work, age, and play. So capability to be healthy is personal, societal, and cultural. So understanding a range of issues which are affected by various institutions, political, economic, legal, cultural, religious. And it is, we know that social conditions, I'm not going to go through those. Concept of social justice is not new. It is that, goes back to 1840. It's all institutions and efforts of the virtuous citizen should be made in the utmost degree to converge. For mentally ill individuals, it's about equality of opportunity and outcomes. And again, I keep using using the term mental illness rather than mental health. Because mental health is something different. And mental health condition, I mean, what does that mean? If somebody stands up and says so-and-so is suffering from mental health, A, should he be suffering if he has mental health? And B, how does that sort of fit in and the broader scheme of things? So, as I said, the clinician focus on symptom reduction, patients in social functioning, and we need to look at the clear evidence that people who have mental illness die 15 to 20 years younger than people who do not have mental illness. Proven time and time again, different countries, different settings. They're not allowed to be full citizens. I think one positive thing that I can think of that Margaret Thatcher did was allowing people in asylums to vote. And recently, if you wanted a visa to the United States and you sort of admitted that you had been admitted to a hospital under compulsion, you could not enter the United States. And that's sort of in my lifetime, so it's not that old. So, as part of the action plan and World Psychiatric Association, we went for social justice for people with mental illness. And I will say, I'm just making you wait for the headline. We commissioned Center for Mental Health Law in Pune to do a global survey. Remember I talked about stigma and discrimination. So the aim was to look at the laws of 193 countries around the globe. Laws, and look at discrimination in law. We just wanted to focus on 4 areas. People with mental illness, their right to vote, right to marry, right to inherit property or make a will, and right to employment. Nothing unusual about that. So, these are kind of social, personal, political, and economic discrimination. So, right to vote is a political right, right to inherit property is economic, right to employment is personal, and right to marriage, social or personal. So we looked at the laws and we searched for the key terms, and I want you to sort of just look at this slide, if you can see at the back. Terms like mental, unsound, insane, infirm, imbecile, disability, disease, etc. And I'm going to sort of just show you the headlines. Only 11% of the countries have no restriction on allowing people with mental illness to vote. In 36% of the countries, persons with mental illness are barred. And another 11% where if you're detained under law, you cannot vote. And if the court declares you insane, in another 29% of the countries, you can't vote. So if I'm an unscrupulous lawyer or an unscrupulous doctor, I can declare anybody insane and, there goes your right to vote. It's in law. Right to employment, same principle. We looked at, similar terms, possibilities of looking at. Again, 65% of the countries define disability, which includes mental illness. And just to remind you that 193 countries are all signatories to the United Nations Charter for the Rights of Persons with Disability. So sign the paper, don't ask them to do anything. It's too painful. again, in theory, 59% of the countries promote employment of people. But 51% of the countries do not prohibit discontinuation of employment on the basis of mental health problems. 51% of the countries. And if you look at right to marry, again, similar principle, we looked at laws, combination of words, only 30% of the countries, there's no restriction. 37% of the countries are barred from getting married, 6% conditional, and 11% of the countries your marriages are rendered void, and 6% have Sharia law. So again, in 63% countries, mental illness is not a ground for divorce. But in Nepal, for example, if you're married and the wife develops mental illness, husband can divorce her, but not the other way around. So, what kind of equality are we talking about here? And what does that mean? And so, 41% of the countries in total who have ratified the United Nations Convention for Rights of Persons with Disability do not allow persons with mental illness to marry. And I was presenting these findings in a country where the Prime Minister and the Health Minister were on stage. So I did this and they all sort of nodded sagely and went off. And when we were queuing up for dinner, people came in, what are you complaining about? I didn't declare anybody insane, as though they were willing to pay my fees. Are you really telling me that you're capable of this? Of course people are. And so the challenge again sort of comes about how do we as professionals respond to that. So right to property, a right to contract, making a will, 21% of the countries allow or recognize right to contract of persons, not recognized in 9%, and another 38%, so 47%. So 42% of the countries deny right to enter into a contract. 71% allow inheritance property, but in 29% cannot inherit property if you have mental illness. So again, if I'm unscrupulous, there are ways I could sort of behave, and 43% of the countries you cannot even make a will if you have mental illness. So, moral of the story is that majority of countries discriminate on some or all of these. Generally, ignoring is the best policy. And is it, related to stigma? And I'm afraid to say that, some of our colleagues play into that. If we as a profession cannot get the definitions right, you saw that slide with, mental, imbecile, insane. If those terms are still being used, then they can be misinterpreted in any which way. We have a problem. So we established this Bill of Rights, and I'm not going to go through that. So there are 15 rights which we launched at the House of Lords in 2016. It's been signed up by 60 organizations, and there are various kind of impacts which are very difficult to judge. But this led to a Bill of Rights for children and young people with mental illness, and also for those with intellectual disability. And subsequently, I think in preparation for Commonwealth Heads of Government meeting last year, when the whole Windrush thing blew up, we did a survey of all the Commonwealth countries, and only 48% 48% of the countries have a mental health policy within the Commonwealth. 52% do not have a mental health policy. So that says something, and only 16% refer to equity of resources. 56% of the policies still believe in institutions and asylums, not closing down psychiatric hospitals, and nearly half do not promote the integration of mental health services and general health services. So, I mean, these are some of the challenges that I've already mentioned to you. So one of the things that we did, we launched this campaign, Social Justice for People with Mental Illness, and we used this blue butterfly as a symbol. Subsequent to that, when I arrived at the BMA, I persuaded them to launch a campaign for health equality between physical health and mental health. So there are butterflies out there. Pick one up, the butterfly outside, wear them with pride. It's a Costa Rican butterfly called Morphomenialis, morpho meaning change. Butterfly represents psyche or soul, and blue is the color of joy, wonder, wish fulfillment. I don't know why people call I'm feeling blue. I'm happy if I'm feeling blue, but that's a different matter. So I think the challenge for any civilized society is, can you really discriminate against people who have an illness, stop them from being full citizens of the country? Part of the challenge of stigma, and we've had endless anti-stigma campaigns over the last 30 years, there's been some shift. And to my mind, I think the biggest shift came about in June 2013, when 26 members of Parliament stood up in the House of Commons and talked about their own personal experiences of mental illness. Charles Walker, who was chair of the all-party parliamentary group, stood up and said, I've got obsessive compulsive disorder, my children call me a fruitcake. And that, I think, to my mind, that will change the dialogue. But we still have a long way to go. And we know that the young royals are very keen on mental health and they're doing their best. But if there are issues related to discrimination in law, then we need to do something about research into psychiatric disorders. Funding is still not good enough. Some attempts are being made, and certainly in many settings the care for patients with psychiatric disorders is not as good as it should be, and we need to deal with this discrimination at local, national and international levels. So I think, as I said, I've got 25 minutes for questions, comments, thoughts, so over to you. Thanks very much for listening.